the registry started in 96, and as you can see on the little chart to the right, you can see that it's been growing ever since. And it's not the number of patients with diabetes, it's the number of patients in the registry. So there's been a long time of sort of getting acceptance for the registry, and now with both the providers and the authorities wanting this, as well as the clinicians where it started, we have an almost 90% coverage of both type 1 and type 2. And since 2018, it's also including all both the children's registry and the adult registry is in the same. And the goal is in diabetes care is at least one annual visit, and that is reported. And last year, with a COVID pandemic, was the first time that we actually had a drop in visits, but it's still 420,000 visits. When you talked about do we know the prevalence or the incidence in diabetes, it's not an incidence registry, it's a quality registry, so we can't really tell, even though we have a high coverage, we're not really sure how many people get diabetes each year. But we can do calculations on that, and we know broadly the prevalence of diabetes. But it's the basic for the quality registry is that we have the information in the medical record to start with. And today, mostly in primary care, it's over 70% that are directly transferred after a clinical visit. And there's also an online registration from clinics, mostly those from hospital clinics, by nurses and physicians after a visit. But to start with, the data we record are very clinically relevant variables in line with national guidelines. And to start in 96, there were not as many as there are today, but we've been very careful about increasing the number of variables. But for instance, the LDL cholesterol was added in 2003, physical activity in 2005, severe hypos in 2009, and just the most recent is the time in range variable. But this is, we want to have high coverage and very high acceptance for the variables rather than to have all interesting variables in the registry. And we have now, since 2017, pilot units using the diabetes questionnaire, adding PROM and PREM data, and then this picture sort of shows how we can access data. This is the group level, easy accessible data, which is on a group level, the units are not anonymous. We can go into this, if you see the center part here, knappen, the button, that you press the button and you get the statistical report that you want. And to the far left, you can see the lipid lowering medication, the proportion of patients on lipid lowering medication, type 1 diabetes, age over 45 years. And you can set this, you want the oldest or the youngest, and you can see that it's been increasing over time. And to the right with the blue bars, you could see that there is a difference on this lipid lowering, the lipid lowering medication in different parts of Sweden. And if I can access my own data, I can click on the blue bar that is Västra Götaland, my part of Sweden, and I will get the green bars, which is every hospital. And I can see that my hospital is in the middle. I can see that certain hospitals have higher proportion of patients. And of course, I don't know if those are with high CVD risk, and there are many explanations for the differences. The point is to be interested in your data. And for instance, the thing with looking at the technologies with the access of sensor-based technologies, a couple of years ago, we could do the same, and we could see there was a big difference. In some parts, there were 80% of patients with type 1 diabetes on sensors. There were 40% in other parts, and that sort of moved the whole spectrum, that patients in regions with less access to technology moved quicker. So it's been used also for everyday clinical life for patients. You can take the next one. And this is just to show the main indicators. We have there are more, but these are the main indicators that we have for benchmarking. So when you open up the registry homepage, you see your unit or your region, in this case, how we measure up compared to a national level. And this is changing every night. Some units they report every day. Some units report only once a year. So that differs, but it is the data set is sort of evolving day by day. But if you get a red dot here, you know that you're below national average, and that should make you go into your own data and see what are we doing? Do we have a special? Can we do something here, or is this is the way it is at our clinic? So these are the sort of the main 12 indicators that we have chosen that are in line with what the National Board of Health and Welfare in Sweden also have set a national target level on. So it's the HbA1c, of course, blood pressure, but of course it's also the process measures that you have your foot examination, your eye examination, in things that you actually can improve. If they're not good enough, we can improve at a local unit level. And of course, from a patient's perspective, it's just a lot of numbers, but it's also a lot of concern and worries about not getting your eye examination on time. So that will also sort of, you can point out that in this region, we don't get to do the eye examinations on time. What can we do about that? Next, please. And this is also an important part of the registry. And this is to really use the register, and we can combine it, link it to other registries, outcome registries, national registries in Sweden. But it's also important to discuss the results. These are patients from Sweden, up to date in real world data. How are patients with diabetes actually, what about their risk? How about risk factor control? Does it matter? We know from many other studies that of course it matters, but really addressing it in a local study with the data from the National Diabetes Registry in their own country, it's an extra, there is a pride from both healthcare professionals and patients contributing to this. And also just we've been doing comparisons to other countries, and that is also sort of inspiring. Where can we improve? How can we do it better? And the top bar picture there is, for instance, that when we have been looking at adherence to lipid-lowering medication. How many, when I prescribe a prescription for lipid-lowering medication, how many patients just really fill them? So we can go out and fill prescriptions and see that there actually is a difference in the rates of cardiovascular events, depending on how you fill your prescription. And this is also something for nurses and healthcare professionals, physicians to address. That does the patient take their medicine, and if they have side effects or whatnot. So just the final picture there is that we started out, the next one. So we started out with clinically relevant variables, easy to feed into the registry. It's not always been easy, but it's with more the getting it online has made it more easy, and the direct transferal from medical records. And the discussion, of course, if my unit has fewer patients reaching targets, that have many different explanations, but it's knowing that my unit, the results from my unit will inspire me and other units. And the register-based research is also important to sort of feedback the new information. So we know what we want to do from guidelines, from research, and we need to see that it's really put into action in diabetes care. So the benchmarking, I saw on your slide that you had the units were anonymous from the start. the units were anonymous in our registry as well. And a couple of years ago, it's all open. And that is actually, we think that is an advantage when the sort of the country and healthcare system is ready for that. It's not to be sort of say that you're doing really poorly. It's to say, how can you improve? Learn from good examples. And the patient involvement is getting stronger and stronger. Patient can access they can access their medical data, and they can also access in the medical records, but they can also access in the registry. And I would say, knowing that my patient can access the medical record makes it a little bit, you know what you're writing, even though you know most people will not read it, but it gets a little thought that you write in a way that could be understood. And it's also the same in the registry, that you could go in, look at your results, and question your diabetes team on how to get the way that you want your healthcare to be in the best way. And the diabetes questionnaire it's just started, but we think we have come a bit on the way. Thank you.